Hello parents, this is Dr. Kant Shah, Pediatric Robotic and Laparoscopic Surgeon, and in this video I will explain how we diagnose and investigate PUJ obstruction in children. This video is part of a series that we are doing in understanding what is antenatal hydronephrosis, PUJ obstruction and the surgery called pyeloplasty. Once hydronephrosis is detected in a child, the biggest concern for families is to understand whether the tests are needed and whether they are safe for their child. Let us start with the most important and most commonly used investigation, the ultrasound scan, also called as sonography. Sometimes it is also called a ultrasound KUB. KUB stands for kidney, ureter and bladder. The ultrasound scan is the first scan which is done in babies and children with suspected pelvic-ureteric junction or PUJ obstruction because it is completely safe, painless and does not involve any radiation, and hence it can be done any number of times safely. This scan helps us assess the size of the kidneys, the degree or grade of hydronephrosis or the swelling of the kidney, whether the swelling is mild, moderate or severe, and we can even take some measurements such as anterior-posterior diameter of the pelvis of the kidney, which is called APD. And over a period of time, this helps us compare these sizes and parameters. It can also tell us how the cortex or the meat of the kidney is behaving and growing over a period of time. Repeated ultrasound scans over a period of time can help us understand whether the hydronephrosis is improving, remaining stable or getting worse. And this is our primary tool for monitoring PUJ obstruction. However, ultrasound scan comes with some limitations. It does show us the structure of the kidneys very well in children and the presence of hydronephrosis, but it cannot tell us how well the kidney is functioning or how efficiently it is draining the urine, and that is why a single ultrasound scan is never enough to make decisions. We rely on several scans done over a period of time, combined with the child's symptoms if present and overall clinical picture. If the hydronephrosis is mild or it improves on follow-up ultrasound scans, we often continue observing the baby without any intervention. And a lot of children fall into this category and do very well without surgery. If the ultrasound scan shows increasing dilatation, thinning of the kidney tissue or the cortex, as I mentioned earlier, or if the child develops symptoms such as pain, fever or recurrent urinary tract infections, then further evaluation is required. In children or babies where the ultrasound scan is suggestive of a worsening or a significant dilatation or hydronephrosis, depending on the size, the cortex and the AP diameter, the next investigation to be done is the diuretic renogram, also called an EC scan. This is a radionuclear scan, which means a small radioactive tracer is given in the veins of the child, which is then filtered by the kidneys and passes through into the urine and then comes out through the bladder and the child passes it from the urine. This study is very important for giving us two main information. One, what is the relative function of each kidney, whether they are clearing our blood 50-50% or there is a difference in the two. And second, whether the urine is efficiently flowing down the pelvic-ureteric junction into the bladder or not, or whether there is a significant blockage or obstruction. This information is given to us in the form of a few images and some graphs. So combining the EC scan and the ultrasound scans, we can make a diagnosis of significant pelvic-ureteric junction obstruction, and this helps us decide whether a child needs surgery or not. Now, sometimes these tests are inconclusive and it is very safe to just repeat them at 1 to 3 month intervals as required. It is never an emergency to operate on a child who has a stable hydronephrosis. Especially at birth, some children who are born with a very large swollen kidney may need an urgent surgery, and hence an EC scan may be even done at 1 to 2 weeks of life. Now, there are some children where all this information may not be 100% enough for us to decide about surgery, especially when there are anatomical or structural variations in the kidney, or that information is not easily available on the ultrasound. The next best investigation is a magnetic resonance urography or a MRI scan. In MRI scan of the kidneys called MRU, we can get very accurate information both on the functioning and also of the anatomy of the kidney. However, doing an MRI scan in a child is not very easy, particularly because of the noise and the time it takes, and hence some children may even need sedation, and this scan is reserved only for some very selected patients. Frequently, we come across children who had a DTPA scan, and this was the scan which was done a lot in the past. So a lot of parents ask me what is a DTPA scan compared to an EC scan and what is the difference. So a DTPA scan is again a nuclear scan with a slightly different molecule called DTPA, and in some places where EC is not available, a DTPA scan can be done. DTPA itself is not very efficiently cleared by the kidneys of babies, and hence this is only done in older children or where EC scan is not available. Primarily, almost all children should undergo an EC scan. So to summarize, by using the right test at the right time, we can protect the child's kidney function while avoiding unnecessary investigations or interventions. The goal is always safe and individualized care with the long-term kidney health in mind. So some children with significant PUJ obstruction will need surgery, and we will discuss this in the next video. It is called pyeloplasty, and almost always nowadays we do it either by robotic or laparoscopy method. So please like and subscribe our videos and follow our channel for more content on this topic. Thank you.